Hello, good morning. I hope you can hear me.
Good
Good
morning.
morning.
Good
Yeah.
morning.
Good morning.
Good morning.
Good morning, good morning, good morning. Welcome to our fourth week of lectures. Welcome to our fourth week of lectures. Last week when we met, we started with pharmacokinetics. We looked at absorption. We looked at distribution. We ended our class with metabolism. So to rehash, we said that absorption is the movement of the drug from the site of administration where you administered it to the blood. So the movement of the drug from where you administered it to the blood or to systemic circulation, that is what we call absorption. When it comes to distribution, the drug or the medicine should not just remain in the blood. It should get distributed to where it's supposed to work. So that's what we call distribution, movement of the drug from the blood to all the various tissues that need the drug so that the drug can perform the work it needs to perform. When it comes to metabolism, you are converting the drug into a form that can be easily excreted. Most of the drugs that you take, they don't like water, but your urine is basically water. So whatever medication you have taken should be able to dissolve in water so that you can pass it out through urine. So metabolism is meant to convert the drug from an oil-loving form to a water-loving form. Under metabolism, we said we had two types. There is the catabolic, and then there is the anabolism. There's catabolism and there's anabolism. Under anabolism, you are building up a larger molecule from smaller ones, and you need energy to do this. For catabolism, you are breaking down larger molecules to form smaller ones. So under metabolism, you can have catabolism and you can have anabolism. There are enzymes that are responsible for metabolism. They include the cytochrome. They are the cytochrome P450 enzymes. There aren't only one. There are multiples of them, about hundreds, thousands of them in the system, whose main work is to break down the drugs that have been taken or to break down all the substances that have been taken into the body. This metabolism that these drugs can perform, that these enzymes can perform, can be done in two phases. There's the phase 1 metabolism and there is the phase 2 metabolism. The phase 1 metabolism is catabolic in nature, whilst the phase 2 metabolism is anabolic in nature. I also used this diagram last week to explain to you what happens in metabolism using aspirin as a case study per se. So for the aspirin, in phase 1, you are breaking down the aspirin. You are breaking down the aspirin to convert it into a form that is more chemically reactive. When you break down aspirin, you end up forming salicylic acid. Which is smaller than aspirin and much more chemically reactive. So in phase 1, you are making the aspirin more chemically reactive by breaking it down to form salicylic acid. In phase 2, you are going to attach a water-soluble substance to the salicylic acid to give you a final compound that is very water-soluble. So it is this final substance that can dissolve in water or dissolve in your urine and get excreted in the form of urine. In this image, we said that drugs can take different paths to elimination. We have some drugs that are already chemically reactive, so they don't need phase 1. They can bypass phase 1 and go straight to phase 2. So if you look at this first drug, it has been able to bypass phase 1 and has gone straight to phase 2. And then from phase 2, it will down get eliminated from the system. For this second drug, two things can happen. It will definitely undergo phase 1, but the metabolite that is formed can still have pharmacological activities, or it can be an inactive metabolite without any pharmacological activity. But whether or not the pharmacological activity, these drugs will still have to undergo, or these metabolites will still have to undergo phase 2 metabolism before they can get eliminated from the system. This last drug is water soluble. It is hydrophilic. So it can on its own dissolve in water. It does not need metabolism. So this means that this drug can bypass phase 1 and it can also bypass phase 2 and go straight to the kidney for elimination to occur. I also said that there are the cytochrome P450 enzymes. About 5 of them are responsible for breaking down or metabolizing about 60% of the drugs that we take. This means that you have a few number of enzymes metabolizing several drugs. So you can have one enzyme metabolizing a multitude of drugs, and you can even have 2 enzymes being responsible for breaking down a single drug, because of these few numbers of enzymes working on these several numbers of medications. So you can have 2 enzymes breaking down one drug, and you can have one enzyme being able to break down multiple drugs. We said that sometimes there are interactions that can take place via induction or inhibition. If you induce the liver enzyme, you will end up making the enzyme work a lot. If you induce the liver enzyme, you'll be accelerating the activity of the enzyme. That means that the enzyme will be breaking down whatever medication is there very quickly. And if you are breaking down the medication very quickly, it means that the levels of the medication in the blood, the concentration of the medication in the blood that is needed to treat disease, or that is needed to treat disease conditions, would not be there. The amount of drug that's supposed to be in the blood to treat various disease conditions, if you induce the liver enzyme, you will break down the medications too quickly and reduce their concentrations. And if that happens, it can result in treatment failure. If that happens, it can result in treatment failure. If you inhibit the enzymes, it means that the enzymes, you are suppressing their activity, and they will not be able to metabolize the medications. And if they're not metabolizing the medication, it will result in the drug being accumulated in the system, and that can lead to drug toxicities. And finally, we said that there are various factors that can affect the metabolism of drugs. We said age, genetics, sex, hormones, disease conditions, diet, environment. These are just a few of the factors that can affect drug metabolism. So this is where we ended last week. So I'm officially done with my rehash. Now we can go and start with today's activities. Today we'll be doing excretion. Your drug has been distributed. Your drug has been absorbed. It has been distributed. It has been metabolized. Now it needs to leave your system. No drug is supposed to stay in you forever. After it is done performing its work, it needs to go. So how do we eliminate drugs from the system? It's by excretion. So drug excretion is the removal of drugs from the body. It is the removal of drugs from the body. Usually, what we are removing are hydrophilic substances. What we are able to remove are hydrophilic substances. If your drug is already hydrophilic in nature when you were taking it in, it means that you don't need metabolism and you'll be excreting the drug the same way you took it in. If the drug entered your system in the form of A, and then that drug on that A drug is on its own hydrophilic, it means that it does not need metabolism and you excrete that drug in its form A. You excrete it unchanged. You will excrete it unchanged. But if the drug that you took in was lipophilic, the drug must be biotransformed via metabolism to give you a hydrophilic metabolite that should now be excreted. There are various routes for drug excretion. There is the kidney, there is the bile, there is sweat, the lungs are also there, and even breast milk. So these are some of the routes of drug excretion. We would start by discussing renal excretion. That is excretion through the kidneys. Excretion through the kidneys. So renal drug excretion is elimination of drugs from the body through the kidneys. The kidney can only excrete drugs that are not bound to proteins. They can only excrete drugs that are not bound to proteins. Drugs that are water soluble and sometimes even unchanged drugs. That is what they excrete. So they will never excrete any drug that is bound to protein. And then they will excrete drugs that are water soluble and drugs that are soluble enough to be excreted unchanged. We have three main processes in renal excretion. There is the glomerular filtration, there is tubular secretion, and there is tubular reabsorption. There are three main processes in renal excretion. There is glomerular filtration, there is tubular secretion, and there is tubular reabsorption. Now, under the glomerular filtration, I think this diagram might be better for us. This diagram might show us a lot. Good. It helps in visualizing what is going on. So we said that there are three types of excretion. There is the glomerular filtration. There is, let me highlight this better. Okay, so there's glomerular filtration. There is tubular secretion. And there is tubular reabsorption. Now let's look and see what exactly is going on. We know that if you look at the anatomy of the nephron, which is the functional unit of your kidney, the nephron there's a glomerulus, which is a ball of blood vessels. So it comes into the Bowman's capsule, calls up inside the Bowman's capsule for a few times, and then it exits the Bowman's capsule. So blood is flowing in through this point, and blood is leaving through this point. Blood is flowing in through this point, and blood is leaving through this point. When there are metabolites of the drug in the blood, and then the blood carries the metabolites into the glomerulus, those metabolites will get filtered out. And when they get filtered out, they will pass through the Bowman's capsule into the tubules of the nephron and get excreted in the form of urine. When there are metabolites of the drug in the blood, water-soluble metabolites of the drug in the blood, those metabolites are going to enter the glomerulus.
Yeah, please, your line is breaking.
Those medications are going to enter the glomerulus. From the glomerulus, they get filtered out into the tubules of the nephron. So they will enter inside this tubule. When they enter, they will stay inside this tubule and get excreted in the form of urine. So this is one way to metabolize, to excrete drugs. But then this glomerular filtration route, it is only drugs that are sufficiently water soluble and drugs that are not bound to any proteins that can undergo this type of excretion. It is only drugs that are sufficiently water soluble and drugs that are not bound to any protein. Those are the ones that are able to get excreted through this route. Apart from glomerular filtration, we have another route that medications can use, and that route is what we call tubular secretion. There are drugs that are water soluble, but they have a certain property that does not allow them to go through glomerular filtration. They rather have to go through tubular secretion. Those type of drugs are usually organic acids or organic basic drugs. So if you are taking a drug like apple cider vinegar, vinegar is an organic it's an organic acid. So it cannot undergo glomerular filtration because it's an organic acid. What happens is that there are, by the side of the tubules, there are various side gates. So what happens is that these organic acids and organic basic drugs are able to enter into the tubules through these side gates. In these side gates, we have something we call transporters. We have organic anion transporter and we have organic cation transporter. The organic anion transporter is going to transport organic anionic drugs, whilst organic cation transporter will transport organic cationic drugs. So they will transport them and push them into the tubules through the side. So we say that this form of excretion is what we call tubular secretion. So when the transporters carries these organic acids and organic basic drugs into the tubule, they will remain in the tubule and get excreted in the form of urine. So this tubular secretion route is reserved for drugs that are organic acid or organic basic in nature. This is what we reserve this group of drugs for. So this is what we have to say about the tubular secretion. Now let's come to tubular reabsorption. We know that Madam.
Sir, please, can you repeat the tubular secretion for us?
No, I cannot. So when I'm done with this, that's when I'll do an all overview. I'm moving forward. When I'm done, I'll do an overview of everything. Good.
Okay.
Sir, please, can you amplify your voice a bit?
It is amplified, Bibrio. Increase your volume. So,
sir, please, your network is also breaking. So if you can position yourself well for us.
I am standing on top of a tree. So I'm positioned perfectly. I am standing on top of a tree. So I am positioned perfectly. MTN is working in my area right now. So I'm positioned perfectly. Okay. So you see, the drugs that are supposed to be passing through this glomerular filtration, like I explained before, There are drugs that are soluble in water and drugs that are not bound to any proteins. Those are the drugs that are able to get excreted through glomerular filtration. But sometimes you can end up having lipid-soluble drugs getting into the glomerulus and getting filtered into the tubule of the nephron. So a lipid-soluble drug can still find its way into the tubule of the nephron. But because it is lipid-soluble, it cannot dissolve inside the urine, so the body cannot excrete it. So what the body does is that it is going to divert this drug out of the tubules of the nephron. So instead of it to go down and get excreted in urine, because it is not water soluble, it cannot mix with the urine. So what does the body do? It will divert it out of the nephron by a process called reabsorption. So this lipid-soluble drug will get reabsorbed back into the blood. When it gets reabsorbed back into the blood, it's going to be sent to the liver for the liver to now metabolize it and convert it into a water-soluble form. The liver can convert it into a water-soluble form, or it can convert it into an organic acid or organic base. If it converts it into a purely water-soluble form, that means that that drug will come back and undergo glomerular filtration and get excreted in the form of urine. But if it is converted into an organic acid or organic base, it has to now get excreted through tubular secretion. Remember, tubular secretion is only meant for what? Organic acidic drugs and organic basic drugs. So if the liver metabolizes the drug and converts it into an organic acid or an organic base, it needs to get excreted through tubular secretion. But if the liver converts it into a water-soluble form that it can freely dissolve inside water, then it will get excreted through glomerular filtration. So, a quick rehash for us to tighten up all loose ends. When you have a metabolite of a drug that is readily soluble in water, it is going to get eliminated from the kidney or from the body through glomerular filtration, where the metabolite is going to get filtered out of the glomerulus for it to enter into the tubules, stay inside the tubule, and get excreted in the form of urine. That is for a drug that is sufficiently water soluble. But we have other water-soluble drugs that are present as organic acids or organic bases. They cannot undergo glomerular filtration. So what do? They have to get in through a process called tubular secretion. There are transporters that are lined up on the walls of the nephron, the tubules of the nephron. They are lining the walls of the tubules of the nephron. So they are going to transport these organic acids and organic bases from the blood and into the tubules of the nephron. From the blood and into the tubules of the nephron. So they are not going through the front gate. They are going through the back gate. And the back gate has gatemen. And those gatemen are the transporters, the organic anion transporters and the organic cation transporters. They would carry these organic acids and organic bases into the nephron through the side gates. When they are able to enter into the side gate, they will now stay inside this nephron or inside the tubules of the nephron and get excreted in the form of urine. They are able to be excreted in the form of urine because they are water soluble. soluble. So that means that your water soluble drugs will get excreted through glomerular filtration or tubular secretion. But if that water soluble drug is an organic acid or organic base, it will get excreted through tubular secretion. Good. But sometimes you can have a wandering lipid soluble drug make its way into the nephron through glomerular filtration. So when it enters into the tubules through glomerular filtration, because it is lipid soluble, it cannot dissolve inside urine and get excreted. If it was possible, you would have been seeing oil in your urine anytime you are urinating, but you never see oil in it unless you have a disease condition. So if that drug cannot dissolve in the urine, then it has no business being in the tubules of the nephron. So what does your body do? Your body is going to reabsorb that drug. Your body will reabsorb that drug back into the blood. When it enters back into the blood, it is going to be sent to the liver for the liver to metabolize the drug from a lipid-soluble form to a water-soluble form. When you get the water-soluble form, the water-soluble form could be an organic acid or organic base. If it is an organic acid or organic base, it needs to now get excreted through tubular secretion. But if it is a free drug that is very water soluble, then that one will get excreted through glomerular filtration. So basically, this is what happens in renal excretion. This is what happens in renal excretion. So everything I have said, I've explained on this slide from slide 22 to 24. So here I said that glomerular filtration is a passive process employed in excretion of free drugs. Free means unbound. Drugs are not bound to any proteins. And then glomerular filtration is affected by renal blood flow and glomerular filtration rate. If you have a patient who has a compromised kidney function or reduced kidney function, and you can sometimes determine that somebody has a reduced function by monitoring the glomerular filtration rate. I'm sure you've seen this parameter in people's kidney function tests. And the ones you have been doing yourself, you've been seeing the glomerular filtration rate. So you can measure someone's function of the way their kidney is functioning by measuring the glomerular filtration rate. So you can use the glomerular filtration can be affected by the rate of the glomerular filtration and then the renal blood flow, how much blood is entering into the kidney. And then 23, yes. For tubular secretion, this involves the active transport of drug molecules from the plasma in peritubular capillaries into the tubular lumen of the nephron. So this involves active transport. We've done active transport last 2 weeks. Active transport is movement of drug substances from a region of low concentration to a region of high concentration with the aid of carrier proteins and ATP. I told you there are special substances that are called transporters that will carry the organic acid and organic base from the blood into the tubules of the nephron. So those transporters are the carrier proteins that is needed. So tubular secretion involves the active transport of drug molecules from the plasma in peritubular capillaries into the tubular lumen. Drugs excreted via this mechanism are usually highly plasma protein bound. That means they are attached to plasma proteins. And then this is because these drugs are not excreted effectively by glomerular filtration. This form of excretion is not affected by the degree to which a drug is bound to plasma protein. Drugs that are actively transported by transporters. These drugs are actively transported by transporters, and those transporters are called the organic anion transporters and then the organic cation transporters. Examples of drugs that are excreted through these means are the penicillins and the cephalosporins. So all your penicillin, amoxicillin, ampicillin, flucloxacillin, all of them are penicillins. And then your cephalosporins, your ceftriaxone, your cefuroxime, your cefixime, all of them are cephalosporin antibiotics. So your penicillins and your cephalosporins are excreted through tubular secretion. When it comes to tubular reabsorption, this is when a non-ionized forms of the drug, ionized form of the drug enters. That is when the drug is what? Lipid soluble. It enters into the renal tubules, but it is going to be diffused out of the tubular membrane, and then it will enter into the plasma. And then these reabsorbed drugs can be sent to the liver to be converted into water-soluble forms. They have to convert it into water-soluble form. And after that conversion, that is when they're going to get excreted. Okay. If your urine is acidic, in nature, you are able to excrete more of the basic drugs. If your urine is acidic in nature, you are able to excrete more of the basic drugs. But if your urine is basic in nature, you are going to be excreting more acidic drugs. You're going to be excreting more acidic drugs. Look at it as your normal integrated science studies you did. Acid base. It is never acid or base. It is always acid base. So if your urine is acidic, you'll be excreting more of the basic drugs. But if your urine is basic, you will excrete more of the acidic drugs. Patients with kidney disease, they usually have problem with drug excretion. So they require for the doses of the medication to be adjusted. Usually, it has to be adjusted downwards so that you don't overload the already diseased kidney. So if someone's kidney is dysfunctional, you don't overload the person with medication. You have to adjust the doses downwards. So the renal clearance is a rate at which a substance is removed from the plasma through the kidney. We have a way of measuring how much of a drug is being eliminated from the body through the kidney, and that is what we call the renal clearance. So we are determining how much of the drug is being removed from the plasma through the kidney at each point in time. That is what we call the renal clearance. We have another parameter that we measure to check how much of the drug is leaving the system, and that is called the drug half-life. The drug half-life is defined as the amount of time at which for the concentration of the drug in plasma to reduce by half. What this means is that how long does it take the amount of the drug in your plasma to reduce by half? So if you give somebody 500 milligram paracetamol, how long will it take for that 500 milligram in the person's blood to reduce to 250? How long will it take for the 250 to reduce to 125? How long will it take for the 125 to reduce to 62.5? That is the drug half-life. The amount of time it takes for the concentration of the drug in plasma to reduce by half. There is a formula for calculating it. Half-life, which has a symbol, this T half, is equal to 0.693 multiplied by volume of distribution, all divided by clearance. All divided by clearance. Why is this important to us to know? Why is this important for us to know? How many milligram of paracetamol should an adult patient, what is the minimum amount of paracetamol tablet should a patient take, an adult patient take, for it to at least appreciably reduce their headache for them? How many milligrams should they take at the minimum?
1 gram. 1 gram.
1
Is
gram.
1
is
gram.
1 gram the
1 gram,
minimum?
please.
Is 1 gram
Yeah.
the minimum or the maximum?
Maximum 500.
The maximum. 500
Maximum
minimum.
is 1 gram.
Maximum.
The minimum
1
will be
gram
what?
maximum.
500.
500.
500 milligram.
500 milligram. Good.
Yes.
Now, let me pose this question. If you had given, your minimum is 500, your maximum is 1 gram. If you have given your patient that 1 gram paracetamol, and then within about 6 hours, the patient is now saying that it's as if the headache has come back again. What do you think has happened? It means that a lot of the drug has been cleared from her system in that 6-hour period, and the concentration of the drug in her blood has now dropped. The concentration of the drug in her blood has now dropped. So if it drops, what do you have to do for the headache to go again? What do you have to do? What do you have to do to help the patient's headache go away again?
You give
The
again.
drug. Give another dose.
Repeat
You
the
dose
dose.
again.
Dose.
You dose again. You would dose again. So if you gave 1,000 milligram, and within 6 hours, your patient is complaining that their headache has come back again, it means that some of the drug has been eliminated from her system, and what is left is too small to perform the work you need it to perform. So what you do is that you will dose again. So when we determine half-life, it tells us how quickly the drug is leaving the system. And it also informs us how often we need to be dosing the drug. So if the half-life of your drug is about 6 hours, it means that every 6 hours, you might need to be dosing again. If the half-life of your drug is 12 hours, it means that every 12 hours, you might need to be dosing again. So the half-life helps us determine the frequency of the dosing. The half-life, it helps us determine the frequency of the dosing of medication. So if you have a short half-life, it means you need to be dosing very frequently, because within a short time, the drug has left the system. But if the half-life is long, it means you need to be dosing less frequently. Azithromycin has a half-life of up to 48 hours, sometimes even up to 72 hours. So that means that for somebody who took azithromycin, it can be in their system for about 3 days before the 500 milligram a person would take would reduce to 250 milligram. So if your drug has a long half-life, you need to dose it less frequently. But if, like paracetamol, the half-life of a drug is about 4 to 6 hours, it means that you need to be dosing very frequently. You need to be dosing very, very frequently. So the half-life helps us to determine how frequently you need to dose a medication. I have another question for you. You gave an adult patient of yours 400 milligrams of ibuprofen. You gave a patient of yours 400 milligrams of ibuprofen. You checked the patient's blood and you found 20 milligram per liter concentration. of the ibuprofen in the patient's blood. You gave 400 milligrams to the patient of ibuprofen. You checked the patient's blood later on, and you found the concentration of ibuprofen in the patient's blood was 20 milligram per liter. If the clearance of that drug is 10 liters per hour, if the clearance of that drug is 10 liters per hour, what is the half-life? You dosed 400 milligrams. Plasma concentration of the drug was 20 milligrams per liter. If the clearance of that drug is 10 liters per hour, calculate the half-life. When you are done calculating, come and tell me in the chat.
Please, you said the plasma is 20 what?
20 milligrams per liter. You gave a patient 400 milligrams of ibuprofen. You gave 400 milligrams of ibuprofen. You checked the patient's blood, and you found a concentration of 20 milligrams per liter. Concentration of 20 milligrams per liter. If the clearance is 10 liters per hour, calculate the half-life. If the clearance is 10 liters per hour, calculate the half-life.
Sir, please, is the 0.693 constant or it can change?
It is constant.
Say ya Mr. Tiafi na mkoye aduana ma mba fa na mko dwan no kura no tehwe.
So I am seeing the answers. Some people are getting weird answers. Others are also getting the correct answers. Constance, kindly unmute yourself and tell us how you got your answer.
Hello, sir.
Yes.
Sir, please, can you go over the half-line calculations again, please?
I can't, because I've asked you a question. Until you are done answering my question, I cannot go through the calculation again. So answer my question first, then I'll go through the calculation.
Hello, sir. Please.
Yes.
What's the clearance meter? I had 10.
The clearance
liters
is 10 liters per hour.
Per hour. Okay, thank you.
Yes. Constance Osayefrie, kindly unmute yourself and tell me how you got your answer.
Hello,
Come and
sir.
remove your mouth. Yes.
Okay, so please, I had 1.386 liter per hour, if that's
Madam,
the unit.
is it liter per hour? Don't come and start changing your mouth. You have written something in the chat.
Hours, 1.386 hours.
So tell me how you got it.
So I got it by multiplying 0.693 by the volume of distribution, which is the 20 milligram per liter concentration.
How did you get the 20? Was that the volume of distribution? That was the concentration. Oh.
Okay, okay.
The concentration was 10, or is it 10?
No,
The
concentration
clearance
was
is 10.
20. Clearance is 10. Concentration is 20
Yeah.
milligram per liter.
So please, I multiply the 0.693 by the 20 milligram divided by the 10 liter per hour. That's how I got my 1
That's how
point
you got your
thing.
answer.
Yes.
Okay. Okay. Thank you so much, Constance. Thank you. Precious. Precious Enim.
Hello. Hello, sir.
Yes, Precious. Talk to me.
I
How did
did
you
the
discuss?
same thing Constance did.
Okay. So you and Constance are sitting in the same place and sharing ideas. Hey, my people.
Can I share my idea?
Yeah, share your idea, please.
So you give the dose of drug as 400 milligram, and then the volume of distribution as 20 milligram per liter.
I didn't give volume of distribution. I gave concentration. I did not give volume of distribution. I gave concentration.
Concentration of drug, yes, as 20. So before
Yes.
you have to calculate for the half-life, you want to find the volume of distribution, which is dose of drug over concentration of drug. So that will be 400 milligram over the 20. And then you get
Hang
divided
on, let me mute the person
you
crying
get
in the
the 20.
background.
Okay.
Please go on.
So you calculate for the volume of distribution, which is dose of drug over concentration. That will give you 20. So when you get the 20, you come and calculate for the half-life, where you multiply the 0.693 by the volume of concentration, which is 20. Then you divide it by the clearance. Then you get the 1.3 hours, 1.386 hours.
Yes. So Juliana is the only one who has given me the right calculation. Let's go over, my people. Juliana is correct. Very, very, very correct. Let's go over. I gave you this formula for calculating half-life. There's a constant here, but you need to get the volume of distribution and you need to get the clearance. I gave you clearance to be 10 liters per hour, but I did not give you volume of distribution. I did not give you volume of distribution. I gave you dose and I gave you concentration. I didn't give you volume of distribution. So that means you need to calculate your own volume of distribution. And how do you calculate volume of distribution? By using the formula I showed you last week. I showed you this formula last week, where volume of distribution in liters is the dose of the drug in milligram divided by the concentration of the drug in plasma. What was the dose in milligram in the question I gave you? My people, what was the dose? 400 milligram. What was the concentration?
20 minutes.
20 milligram per liter. So when you do, so that means you have the dose, you have the concentration. You can now go ahead to calculate for volume of distribution. So it's going to be the 400 milligram divided by 20 milligram per liter. When you finish calculating for that, you will get your answer to be 20 liters. So your volume of distribution will be 20 liters. When you are done calculating for the volume of distribution, that is when you will now come back to this formula. That's when you come back to this formula. Now, you can now put in your volume of distribution here so that you have 0.693 multiplied by the 20 liters volume of distribution all divided by the clearance, which was 10 liters per hour. And your final answer will be 1.386 hours. 1.386 hours. And that would have been your half-life. Those of you who used only the concentration, you got the same answer just by luck. You got the same answer just by luck. But
Yes, yes.
if the volume of distribution did not have the same value as the concentration, your answer would have been obviously, you would have seen that it's deviating. So your calculation was wrong, but your answer was correct because you were lucky. You were lucky. But if I ask you a question in exam and I see the calculation is wrong and the answer is correct, everything to me is wrong. Everything to me is wrong. You even half mark you won't get. Even for your ink cry, you won't get. You get a big zero. And I'll put two eyes in the zero and put a nose and put a smile on it too, on top.
Hey.
And I'll call your name and I'll tell you that you did it wrong. So you were just lucky. You were just lucky. So please stop being lucky. Stop being lucky. Okay. So that is how you calculate for such a question. That is how you calculate for such a question.
Sir, please, one question. Sir, please, with the the half-life, have you seen it has a symbol of T half?
Mm-hmm.
Do they have any effects on the answer? Or
No,
it's just
no, it is just a symbol. It's just a symbol.
Okay, thank you.
It's just a symbol. You're welcome. Good.
Hello, sir. Please, so
Yeah.
after getting the 20, will it be in milligram or I'm talking about the unit for half-life?
Half-life.
Because
Based
after
on
getting
what calculated, your half-life is in hours.
Oh, okay.
Yeah, it's in hours. Almost all half-life is calculated in hours.
Okay.
Okay. So we have factors that can, yes.
Sir, please, so. But how would we know? Like the question you just gave us, how would we know that you have to go back to that previous formula you gave us no? To be able to calculate before we now, like if the question is set, how would we know that you have to go and pick that formula before you come and get the actual answer here? That's my worry.
That's your worry. Okay. Now, based on the parameters I gave you, did you see volume of distribution part of it?
No, please.
I gave you dose. I gave you concentration. I gave you clearance. Was volume of distribution part of the parameters I gave you?
No, please. You didn't.
No. But if you look at the formula, you need volume of distribution to calculate for half-life. True or false?
True.
So that means that if you don't get the volume of distribution, you can't calculate half-life. So your first distinction now be, your first thought should be, how do I now calculate for the volume of distribution? Unless you have used the chicken you are going to chew during this Valentine's Day to format your hard drive, which is your brain. This is when you forget that we did volume of distribution last week. But if you remember we did volume of distribution last week, you know there's a formula there that can be used to calculate for the volume of distribution. So because you are lacking that value here, you will now know you have to use that formula that I gave you last week to calculate for the volume of distribution before you can now move ahead and calculating for your half-life. So how do you know you need to do a calculation by the side before you come to this main one? You know because I haven't given you all the parameters. I did not give you volume of distribution. So you need to calculate it yourself to be able to use it. So when I give you a formula and I give you parameters and you find that one of the parameters is missing That means you have to determine it yourself before you can put it into the formula and calculate. I hope this is enough explanation.
Yes, sir. Thank
Good.
you.
You're welcome. You're welcome.
Hello, sir.
Yes.
Please, this is Francisca. Good morning.
Good morning.
Sir, please, during exam, are we going to use calculator or we can send our phones today for the calculator?
Please, you can't send your phone. Oh. Your phone enters examination hall. It is malpractice. So all you can do is calculator.
Okay.
So
Thank
bring
you.
a calculator when you're coming. And some of
Yes,
you,
sir.
after
Thank you.
SHS, you gave your calculators to your siblings and you said, me and mathematics, we are done. When I was this year, you're back to meet mathematics. So please go back to your siblings and take back the calculator you gave them. If you
Okay.
can't find it anymore, go and buy. Yo. And we haven't even started the main calculation. Oh, you're about to get there. Don't worry. So please go back to your siblings and go for the calculators you gave to them.
I'm starting. Some of us are dead.
So factors influencing renal excretion. Factors influencing renal excretion. Kidney function is one of them. If the person has a reduced kidney function, it means that their kidney is not working properly, and that can affect the excretion of medications from through the kidney. Protein binding. If your drug is bound to protein, it can impede its excretion. It can impede its excretion. If your urine pH is acidic, you'll be excreting basic drugs. If your urine pH is basic, you'll be excreting acidic drugs. Urine flow. When somebody is not producing or is not urinating, you can tell there's something wrong with the person's kidney. And then that can also impede the excretion of drugs through the kidneys. So these are a few of the factors that can affect renal excretion. So with this, we are done with renal excretion and we can move on to biliary excretion. We can move on to biliary excretion. When it comes to biliary excretion, it involves the active secretion of drug molecules or metabolites from the hepatocytes into the bile. I don't want to talk plenty, so I will use this diagram to explain what is happening. There is biliary excretion, but how does it happen? So in biliary excretion, you are going to be excreting the medication through fecal matter. The medication is going to be excreted through fecal matter. What ideally goes on is that you have your drug that has been sent to the liver for metabolism. Your drug has been sent to the liver for metabolism. When this drug is metabolized, you will end up forming a conjugate. When this drug is metabolized, you will end up forming a conjugate. Sometimes this conjugate is what is sent to the kidney for excretion. But the kidney is not the only organ that the body uses for excretion. The body can also excrete through fecal matter. If your body wants to excrete this conjugate through fecal matter, your body is going to send this conjugate into the bile. It will send it into the bile. And we all know that in the gallbladder, the bile is stored there. So that means that this conjugate will also be inside the bile that is in the gallbladder. And this gallbladder can release the bile into the intestine. It can release the bile into the intestine. So when the bile containing the conjugate is released into the intestine, the conjugate will now land in the intestine and is supposed to pass through the large intestine, make its way into the rectum, and get excreted. So ideally, this is what is supposed to happen. Your drug is metabolized into a conjugate. The conjugate is sent into the bile to be stored in the gallbladder, so that when the gallbladder is secreting the bile into the colon, the conjugate will also go there and get eliminated through the through fecal matter. This is what is supposed to go on. But we have found out that there is something going on in this process that can affect the way the drug is being excreted. And what is it? It is something we call enterohepatic cycling. It is a process we call enterohepatic cycling. What is it? And let me take you deep and let's see what goes on there. You see, in enterohepatic cycling, your drug is metabolized to a conjugate. The conjugate is sent to the bile. The bile has been secreted into the intestine. The bile is supposed to travel through the intestine and end up in fecal matter. But in enterohepatic cycling, what goes on is that when this conjugate ends up in the intestine, in this intestine, we have enzymes and we have bacteria. And these enzymes and bacteria are able to break up these conjugates to give you back your drug. I don't know if you recollect what a conjugate is, but for those of you who have forgotten what a conjugate is, let me go back and show you what a conjugate is. This entire structure is a conjugate, which is a fusion of salicylic acid and a different substance. Salicylic acid and a different substance. That is what we call the conjugate. When the enzymes and the bacteria perform their function, they are able to break up these conjugates. They are able to break up this conjugate. That means you have separated this portion from this portion. You have split the conjugate into two. And when you split it into two, you will end up forming this salicylic acid again. You will end up forming salicylic acid again. So in the intestine, we have bacteria and we have enzymes that are able to break up this conjugate to give you back the drug. To give you back the drug. So this is what I mean when I say that the conjugate is broken up. The conjugate is broken up. So when the conjugate gets broken up to give you back your drug, what happens? If you remember what we did last 2 weeks, when we did absorption, we said that in the oral route, when your drug is in the intestine, there are blood vessels in the lining of the intestine called portal veins that will carry the drug and send the drug into the liver. So this your drug that you have formed by breaking down this conjugate is now going to be sent back up into the liver through the portal vein. Through the portal vein. Now, this your drug has come back again to the liver. The liver has two options. It is either it is going to metabolize this drug back into the conjugate for this system to go over again. And if it does that, it means that the drug is going to be moving in circle from drug to conjugate, conjugate in the liver to conjugate in the intestine. From conjugate in the intestine, you will form back your drug again. Your drug is going to go back
Your
into the
network
liver.
is breaking.
Is it breaking for everyone?
Yes,
Yes.
sir.
Yes.
Yes, sir.
Yes, sir.
Yes, please.
Yes,
Yes,
sir.
sir. Yes, sir.
I have come
Yes,
down
sir.
from the tree. That is why. So I'm going to climb up again. Don't worry.
Okay, sir, then go back, please.
So your drug that has come back to the liver, it can either be sent. The liver can choose to convert into the conjugate again. From the conjugate in the liver, it can be sent back into the intestine. In the intestine, the body will convert it back into the drug again, then to come back into the liver to conjugate in the liver to conjugate in the intestine. So you end up moving in what? In circle. You will end up moving in circle. And if your drug is moving in circle, it means you are not going to be excreting the drug out. The drug will be staying longer in your system. The drug will be staying longer in your system. So this cyclic motion is what we call enterohepatic cycling. Entero meaning for the intestine, hepatic meaning the liver, moving around in what? In circles. Enterohepatic cycling. Sometimes when this drug also comes back to the liver, it can be sent back into the blood, into general circulation to go and perform more work in your system. So that means that no matter what, if this enterohepatic cycling is going on, the drug is staying longer in your system. And if you are not lucky, and this enterohepatic cycling is taking place, and you are still dosing the medication, the drug that is supposed to leave your system is not leaving. It is still lingering around. And you are still going on to dose more of the medication. What you see is that you will have the drug begin to accumulate in your body, and that can lead to drug toxicity. That can lead to drug toxicity. So enterohepatic cycling can make the drug stay longer in your system. It can make the drug stay longer in your system. And if it is staying longer in your system and you're still dosing the medication, it can reach to toxic levels for the patient to begin to now experience drug toxicity. So let me go over one more time for those of you who said my network was staying poor. So your drug is in the liver. Your liver is going to metabolize the drug into a conjugate. This your conjugate, it can be stored in the gallbladder. When the gallbladder begins to secrete the bile, the conjugate mixed together with the bile is going to be sent to the intestine. Ideally, this conjugate is supposed to mix up with fecal matter and get excreted. But sometimes we realize that there are bacteria and there are enzymes in the intestine that can break up this conjugate to give you back the drug. When you get the drug back, it can get reabsorbed or can get taken up through the portal vein back into the liver. So what was supposed to have been excreted is now going back into the liver. In the liver has two options. It is either it pushes the drug back again into systemic circulation to go and perform more work, or it is going to metabolize the drug again and convert it into a conjugate. If it converts into a conjugate, this entire process will take place again. This entire process will take place again, where the drug is sent to be converted to a conjugate. It ends up in the intestine. It gets broken back again into the drug, and it gets sent back into the liver. So it's just going round and round in what? In circle. So this cyclic motion is what we call enterohepatic cycling, where your drug is moving round and round between the intestine and the liver. It is moving round and round between the intestine and the liver. If this entire hepatic cycle is taking place, it can signal you that the drug is staying longer in the system. And if you are still dosing the medication, it means that what was supposed to have left the system is still in your body and you're adding more. The more you add, the greater the levels of the drug in your body. And when it gets too high, it can lead to drug toxicity. It can lead to drug toxicity. That's when you begin to experience the toxic effects of the drug, because the drug is accumulating in your system. Because it is accumulating in your system. So this is what enterohepatic cycling is. For those of you who cannot spell enterohepatic cycling, please, this is how you spell it. Enterohepatic cycling. So everything I have said can be found on this slide number 28. Everything I have said plus additional information can be found on this slide number 28. And you have this slide, so please read it. So this is what is taking place in enterohepatic cycling. Apart from excretion through the bile, we can also excrete through the lungs. That is when gaseous lipophilic drugs are excreted out when somebody is expiring air. So you can have excretion through the lung. We call it pulmonary excretion. You can also have excretion into the breast milk. That is when medications can get inside the breast milk, so that when the baby suckles, the baby is going to be drinking the medication in the breast milk. So the breast milk, some of the drugs can enter there. And when the baby suckles, they can end up taking in the medication. That is in situations like this that we say that certain drugs should not be given to breastfeeding women. It's in this situation that we say certain drugs should not be given to breastfeeding women. Example, diazepam. Diazepam can enter into the breast milk such that when the baby suckles, the baby will be taking in diazepam. And that can be bad for the baby. So you can have excretion through the breast milk. You can also have excretion through the saliva. That is how you can take a medication. And from the moment you take the medication, your saliva will be bitter till you are done taking the drug. Because the drug is being excreted into the saliva. And every time there's saliva in your mouth, so every time the medication is being tasted in your mouth. So that is how some of these excretion processes take place. So you can have pulmonary excretion, you can have breast milk excretion, you can have salivary excretion. So these are other forms of excretion. They are non-renal excretion together with the biliary. So biliary is an example of a non-renal excretion. So in conclusion, regarding the processes involved in pharmacokinetics, you have administered the drug either through the oral route, inhalational route, parenteral route, but whatever you did, it finds its way into the blood. So this is where you have your blood. It finds its way into the blood. In the blood, it can get sent to where it performs its work. It can also get stored in body tissues. When it is done performing its work or it is done being stored, it can come back again into the blood and be sent to the liver for metabolism to occur. After metabolism is done, it can be sent back into the blood for it to be sent either to the bile, to the lungs, or to the kidney for excretion to occur. So these are the processes involved in pharmacokinetics. You have absorption, you will have distribution, you will have metabolism, which occurs in the liver, and then you will have elimination, which can occur through the bile, through the lungs, through the kidney, the breast milk, the saliva, the what else again? The bile, so many things. So you can excrete through all these processes. You can excrete through all these processes. But before we can finish with pharmacokinetics, we need to take a closer look at certain parameters, something like what we call the onset of action. Onset of action just means the time between when you administer the drug to the patient to when the patient begins to see therapeutic effects. You gave para to your patient, and then your patient was complaining that still the headache is still present. But after about 1 hour, the patient now says, okay, I can now feel that my headache is going down. That means that the time for onset of action is what? 1 hour. That's the time between from the time you gave the medication to the time the person begins to experience therapeutic relief. That is what we say is the onset of action. Duration of action is how long the drug is performing its work in your system. So it's the length of time the drug is producing a therapeutic effect. The length of time the drug is producing a therapeutic effect. Some drugs can have a long therapeutic effect, others will have a short therapeutic effect. That is why your diclofenac has about 12 hours therapeutic effects, but your paracetamol has about 6 to 8 hours therapeutic effect. So those are some parameters, but we need to take a closer look at how this actually occurs using the drug plasma concentration versus time curve. Using the drug plasma concentration versus time curve. So what is this? So let's say you give your patient paracetamol. And when you give the patient the paracetamol, it was at time 0. You give it to your patient at time 0. And then as time goes on, you want to be measuring the amount of the medication. So you are measuring plasma concentration of the paracetamol in the patient's blood. If you are measuring the plasma concentration, you see that at time 0, there will be no amount of the drug in the patient's blood unless you give the patient IV medication. But if you give oral medication, there will be no amount of the drug in the patient's blood at time 0. But as time goes on, the amount of the drug in the patient's blood or the concentration of drug in the patient's blood will begin to rise. It will rise till it hits its peak. After hitting its peak, it will now begin to what? Decline. It's now begin to decline back down to the normal level, back down to 0, if possible. Now, I have a question for you. Between absorption, distribution, metabolism, excretion, which one of them or which of them we can choose one as your answer, you can choose multiple as your answer, you're free to choose. But of these 4, which of them is responsible for the rise in plasma concentration of the drug? Tell me. You have absorption, distribution, metabolism, excretion. Amongst these 4, which of them will be responsible for the increase in plasma concentration of the drug?
Absorption and distribution.
Distribution and absorption.
And distribution, please.
Do we all
Distribution
agree?
and metabolism.
Hey. Absorption and
Distribution and absorption.
Okay. I am getting concerned. People are saying absorption. People are saying absorption and distribution. People are saying distribution and metabolism. Nobody is saying excretion. Shame on you. You don't like excretion. Shame on you. Shame on all of you. So please let us go.
Elimination and distribution.
Let us see. Hey, as for you, they are claiming everything.
Absorption and metabolism.
She has claimed everything. Okay.
Yeah, it's about absorption, distribution, and elimination.
And elimination, all of them is part. If your own is select all. All of the above is the answer. All of the above. Okay. Let's go and see exactly who is correct and who is wrong. And I'm going to laugh at those who are wrong. Now, is it absorption? What is absorption? Absorption is the movement of the drug from where you administered it till it enters the blood. If it enters the blood, there is distribution. There's plasma in your blood, right?
Mm-hmm.
Your blood is made up of plasma, right?
Yes.
So if the amount of the drug entering the plasma is increasing, it means that the plasma concentration will be what? Increasing. So absorption, the drug moving from administration site into the plasma, would elevate plasma concentration. So those of you who said absorption, you are correct. If you said absorption, you are correct. Now let's go to distribution. What is distribution? Distribution is movement of the drug from the plasma or from the blood to other parts of the tissues that need the medication. If the drug is entering the tissues, is it still going to be in the plasma?
No. No.
No. So will plasma concentration be going high or will it go down?
It will go down.
It will go down. So that means that distribution will reduce plasma concentration. So those of you who said distribution, you are wrong. If you had distribution in your answer, you are wrong. Now let's come to metabolism. In metabolism, is the drug being sent to the plasma to work, or is it being sent to liver to be broken down?
It's being sent to the liver to be broken down.
So would the amount of the drug in plasma be increasing?
No.
No. So that means that metabolism will not allow plasma concentration to go high. It will make it come down. And how about your elimination? Will it make plasma concentration go high?
No.
No. Because you are removing the drug from the body. So the only thing responsible for the increase in plasma concentration is absorption. That's distribution, metabolism, and excretion will make the plasma concentration come down. It makes plasma concentration come down. So let me start calling names. Sabina Kwansa, you are wrong. Abigail Inti, you are wrong. Jennifer Witeku, you are wrong. Miriam Adi, you are wrong. Ruth Atiso, you are wrong. Teresa, you are wrong. Benedicta is correct. Let me not even focus on the correct people. The wrong people are the ones that are interested. Jennifer
mental health.
Priscilla Frimpong, you are wrong. What is it? Gifty Kwabi, you are even wrong times 3. So who are wrong? Now you know yourselves. Now you know yourself. The person cooking in the background, please stop cooking. Stop using utensils. So we know that absorption is going to make plasma concentration go high, but then distribution, metabolism, excretion will make plasma concentration come down. But if you look at this graph, you'll see that there has been split into 3 main segments. We have the, let me clear the screen so that we can see better. We have the subtherapeutic region, we have the therapeutic window, and we have the side effect region. What does this mean? if you give somebody 1,000 milligram of paracetamol orally, all the 1,000 milligram doesn't enter the person's blood at once. It enters in gradually. Let's say that the medicine can start working at 500 milligram. It will start reducing the headache at 500 milligram. But then by 1,000 milligram, it should have hit the maximum. By 1,000 milligram, it should have hit the maximum headache relief. But it means that as the medicine is entering into the person's blood, from plasma concentration of 1 all the way to 499, you would not see any effect of the drug. So we call this region the sub-therapeutic window, or the sub-therapeutic region. From 1 to 499, you would not see any effect of the drug. We call it the sub-therapeutic region. So from this point, all the way to this point is what we call the sub-therapeutic region, because any plasma concentration in this range will not result in any headache relief. From 1 to 499, the patient will not experience any headache relief. But they will experience headache relief from 500 milligram to 1,000 milligram.
Hi.
That means that from this point
Go.
the patient is going to experience headache. From this point to this point, the patient will experience headache relief. That's what we call the therapeutic window, where the drug can perform its work. From 500 milligram to 1,000 milligram, the patient will experience the therapeutic effects of the drug. But if Oyansafo goes and gives additional tablets, maybe they go and add one more tablet to the 1,000 milligrams to make it 3 and all.
Valentine gift.
In pharmacology, I think Valentine gift, Madam Yvonne is collecting Valentine gifts in pharmacology class. And I mute her and she'll mute herself.
Please mute yourself.
So let's say somebody has taken the 2 tablets. Who is this one too? So let's say that after the 1,000 milligram, the person says, "Oh, it's as if the 2 tablets is small. Let me take another one." And in fact, let me just send this person to the waiting room.
Sir, please do so. Hey.
So after the 1,000 milligram, maybe the person says, "Oh, it's as if the tablets are too small. Let me go and add more to it." And they go and add one more tablet to it. After adding the one more tablet, the concentration of that drug in the plasma will now go beyond the therapeutic window and enter into the side effect. No, I already moved to the waiting room. She'll be there at the end of the class. Okay, so if the person goes to take additional tablets, it means that the concentration in plasma will go high, and enter inside the side effects region. That's where the person will begin to experience the toxic effects of the drug. And we don't want that. So ideally, we want the plasma concentration of the drug to only remain in the therapeutic window. We don't want it to go up and enter into the side effect region. We don't want it to go up and enter into the side effect region. We only want it to remain in the therapeutic window. But the drug goes up and absorption ends, and then distribution, metabolism, and excretion begins to take place, and the plasma concentration begins to drop. When it begins to drop, it is going down the therapeutic window until it leaves the therapeutic window. When it leaves the therapeutic window, the person will tell you, my headache is back. My headache is back. And when the headache comes back, you now have to dose again for the drug to go up into the therapeutic window and remain there. Let me wipe all this my screen because the screen is getting blurry. So you have given the drug, absorption is over. Distribution, metabolism, and excretion are making the drug's concentration in plasma go down. So it will go down, 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 down until it leaves the therapeutic window at this point. When it leaves the therapeutic window, the patient's headache will come back. If the patient's headache comes back, it means that your drug has left the therapeutic window and is now back again into the sub-therapeutic region. When it comes to the sub-therapeutic region, you need to dose again. If the patient's disease condition is not gone, you need to dose again so that the concentration will go back into the therapeutic window. So we always want the concentration to remain in the therapeutic window. If it goes down and enters the sub-therapeutic region, the person will not experience the beneficial effect of the drug. So all the time, we want the drug's concentration to remain inside a therapeutic window. When we say the duration of action, it is the point from which the drug has entered, or the period of time from which the drug enters the therapeutic window to the time the drug is leaving the therapeutic window. From the time it enters to the time it leaves, that is what we call the duration of action. So if it is entering at 1 hour and it is leaving at 5 hours, it means that within this period is what we call the therapeutic window. And it's what we call the duration of action. So that duration of action is how many hours? 4 hours. It is 4 hours. So the time it enters to the time it leaves, that is what we call the therapeutic window. That is what we call the therapeutic, the duration of action, sorry. We call it the duration of action. We call it the duration of action. Onset of action is the time it takes for the drug to now enter the therapeutic window. This 1 hour will now be the onset of action. From the time you administer the drug to the time it enters the therapeutic window is what we call the onset of action. So in this example I have given, 1 hour is the time for the onset of action of the drug. 1 hour is the time of onset of action of the drug. So bear in mind that the time of exit of the drug from the therapeutic window is what is going to tell us how frequently we need to dose the drug. So if every 5 hours from the point of administration to the point of exit, the drug is leaving the therapeutic window, it means that we need to be dosing this drug every 5 hours. Every 5 hours you dose again. Every 5 hours you dose again. So the drug that you have been given every 12 hours, it might be because the drugs, from the time the drug is administered to the time the drug leaves the therapeutic window is 12 hours. That's why you're dosing every 12 hours. If you're dosing every 8 hours, it means that from the time you dose the drug till the drug leaves therapeutic window is about 8 hours. That's why you keep on dosing every 8 hours. So this is just something to bear in mind with regards to the way the pharmacokinesis of the drug can affect the way the drug is working. So the plasma concentration enters therapeutic window, we like it. It enters side effect region, we don't like it. It stays in the sub-therapeutic region, we also don't like it. We only want it to remain in the therapeutic window. We only want it to remain in the therapeutic window. So with this, we are done with pharmacokinetics. kinetics. And when we meet next week, we will do pharmacodynamics. It is a short slide. We will do the pharmacodynamics, and we will do we'll do pharmacotherapeutics next week. When we are done, we'll start discussing in the fifth week all the various drugs that we use in treating disease conditions. So next week, we will do pharmacodynamics and we will do pharmacotherapeutics. And then afterwards, we will start discussing all the various drugs we use in treating disease conditions. So I'm now opening the floor for all your questions, if you have any.
Sir.
Yes.
Please, me, I'm making an appeal about the calculation. I didn't get it. So if you can
what is the appeal?
So that you please take us through it again.
What didn't you, not us, you're talking about yourself, or not us.
Okay, myself.
What didn't you get the first time?
What we just calculated.
Yes. What didn't you get in the calculation?
How they get the is it the answer? Said that calculation they did. I didn't get it.
I'm asking, which part of it didn't you get?
Say everything about the calculation. I didn't understand.
Everything doesn't go down well with you. In perspective, I can know I can start solving your problem. Did you understand the question?
Yes, please.
What was the question? I'm waiting for you. What was the question?
Sir, I can't remember the question.
Madam.
Sir, can I help you?
Let the lawyer help me.
That means you not write the question down. You see,
Sir, I only wrote the figures down. We have 400 milligrams. Then the 20.
What did the 400 milligrams represent?
Sir, I didn't get the whole thing. Before I came in, it's like you've already read the question out.
Now you have stated your problem. The problem is not that you did not get it. The problem is that you did not come to tune into the class. So by the time I had gone through the question, you weren't around.
That's why earlier on said I'm making an appeal.
But it's not what the appeal was. Now I know what your problem is. And now I can solve your problem. Okay. Your problem is you're not coming. So let me go back and explain what you missed. I gave a scenario. I had wanted you to calculate for half-life. That was the question. I wanted to calculate for half-life. But I gave you certain parameters. I told you that you gave a patient 400 milligrams of ibuprofen. You gave your patient 400 milligrams of ibuprofen. After a while, you checked the patient's blood and you found the concentration of ibuprofen in the patient's blood was 20 milligrams per liter. You also found that the clearance of ibuprofen is about 10 liters per hour. About 10 liters per hour. So the question now is calculate for half-life. You have been given the dose. You have been given the concentration of the drug in plasma. You have been given the clearance. And I'm asking you to calculate for the half-life. I gave you clearance. I gave you dose. I gave you concentration. I did not give you volume of distribution. But before you can calculate for half-life, you need the volume of distribution. So that means I need to go and calculate for the volume of distribution. How do you calculate for volume of distribution? We did that last week, where I gave you this formula. I gave you this formula to use to calculate for your volume of distribution. And what is the formula? The dose of the drug in milligram divided by the concentration of the drug in plasma. Based on the question I gave you, the dose was what? 400 milligram. The concentration was what? 20 milligram per liter. So when you do your calculation here, the 400 divided by the 20, you will end up having 20 liters. You will end up having 20 liters. So that 20 liter is now your volume of distribution. It is now your volume of distribution. So you will take that 20 liters and come back to the half-life formula. And this is the formula. And you will now put the 20 liters. You have 0.693 multiplied by your 20 liters divided by the clearance, which I gave you to be 10 liter per hour. When you calculate for it, you will end up with your answer of 1.386 hours. When you calculate for it, that's what you end up getting. So I gave you dose, I gave you concentration, I gave you clearance. I did not give you volume of distribution. You need to use the dose and the concentration to calculate volume of distribution. Then you put it in the formula and you solve for it. And that is basically how you do it. Good. I hope Idris is okay now.
Okay, sir. Thank you.
If you don't practice it, you would not know how to do it. So practice it.
Hello, sir. Hello, sir.
Yes.
Sir, please, how are you going to know that this is the dose of the drug and this is the concentration?
It's already in the question I gave. I told you that you gave somebody or you administered 400 milligrams. What are you administering? Isn't it dose?
Yeah.
So if I said in a question that you administered 400 milligrams, that is obviously the dose. And because of the question, this is not the first time I've heard this question before. Because of that, I'll never put in this is the dose. I'll always say you administered, or I'll find a different way of putting it. I'll never put the word there dose. Because you should know that it is the dose you are given. So it will be there in the question. The concentration will be stated. I also said in the question that the concentration of the drug in plasma was 20 milligram per liter. I stated that one clearly. So all the things you need to be in the question. I don't need to say dose is equal to, concentration is equal to. I will describe it in a sentence because that is how you'll be experiencing it in your facilities. Nobody will come and say dose is equal to. They will say, give this person this, give that person that. You should know that is the dose they're referring to.
So, sir, please, the plasma too is the concentration.
Yes, I said the concentration in plasma. Yes. So that is still concentration.
Please, I have a question.
Mm-hmm.
Sir, please, my question is on the half-life. So you said the drug half-life, it determines or if it informs the clinician on how often a dose should be given or how often to dose required. You see, the anti-malaria drugs, mostly the first and the second dose is within a period of 8 hours, and the subsequent ones are within 12 hours. Does that mean the half-life of the first and second dose are shorter than the subsequent ones?
You see, the 12 hours is even more likely. Okay. The first 8 hours, the reason why we give it in the first 8 hours is because we want the concentration of the drug in plasma to go very high. We want a high concentration of the drug in plasma. That's why we don't wait. we give it in duration, a period of 12 hours, so that it can drive the concentration very, very, very high to be able to clear the parasites in the blood very quickly. That's why you put it that way. But ideally, it should have been 12 hours. But because we want the concentration very high, that is why we are using the 8 hours during the first 2 doses. I hope that explains your question. Okay.
Okay. Sir, please, my second question.
Sir, please, my question.
Wait, Teresa.
You said that, sir.
Mm-hmm.
Sir, please, my second question. When we were doing the excretion by the kidneys or the renal excretion, you said that drugs that are bonded to proteins are not excreted during the glomerular filtration. Drugs that are bonded by protein. So why is it that sometimes our pregnant women have protein in their urine?
That means there is problem.
Because they are saying they cannot,
kidney.
drugs bonded to proteins are not excreted. So
but you
why?
see, when you see
How?
protein in the urine, when you see protein in the urine, when you see protein in the urine, when you see protein in the urine, Madam, your network is
Sir,
not good.
did you hear me?
I heard you. I heard you.
I was saying that. Yeah. Okay.
I heard you. When you see protein in the urine, ideally, protein is not supposed to be excreted through the urine. You're not supposed to be seeing proteins in your urine. You're not supposed to be seeing them. That you are seeing protein doesn't also mean that a drug is being bound or there's a drug bound to that protein. It doesn't mean that. If you are seeing protein in the urine, there's something wrong in the kidney. If you are seeing protein in the urine, there is something wrong with the kidney, ideally. But I think for pregnant women, we don't get as alarmed as we usually do for the normal person who is not pregnant, because pregnant women are aliens. What is considered normal for a pregnant woman is abnormal for other people. For a normal non-pregnant person, is abnormal for that person. Even the way we diagnose anemia is different from how we diagnose it from a normal person to a pregnant person. So there are peculiarities in pregnancy that would make unusual things happen in them. And these peculiarities might leave room for interpretation. They might leave room for interpretation. But then, ideally, you should not be seeing proteins in your urine. If you see proteins in your urine, it means there is something wrong with the kidney. Ideally, there's something wrong with the kidney. But I think for pregnant women, we don't get as alarmed as we would have been if the person wasn't pregnant. I hope this helps to explain your question, Teresa.
Yes, sir. Sir, please, last one. So with the enterohepatic cycling, you said that when there is this cycling going on, the drug should not be administered again, or easily dose the client again. But since it's happening in the body, how are you going to know there is enterohepatic cycling? Is there any signs and symptoms that is going to notify you, the clinician, so you don't dose again?
You see, that's the thing. Things like that you would not even see. Things like that you would not even see. But then we know that there are certain drugs that can undergo this enterohepatic cycling. So if you are administering such a drug, that means you need to be extra careful and be monitoring for possible signs of toxicities for those type of drugs. But if not, if the drug doesn't fall under that class, then you have nothing to worry about. So you just note those drugs, and then when you're giving those drugs, you can be proactive in checking for signs of toxicities.
Okay. Thank you, sir.
Welcome.
Hello, sir.
Lydia Ponsa, what's your question?
Hello, sir.
Yes, Lydia.
Sir, please, during the drug plasma concentration verse time, that hepatic conjugate repeats itself.
Wait, I'm coming.
Okay.
This diagram.
Yes, please.
Repeat your question again.
Sir, I said during the plasma concentration verse time, does the enterohepatic conjugate repeat itself?
Okay.
cycling process.
Is that correct? Okay. So your question is, if I'm understanding you, what role would the enterohepatic cycling play in this diagram?
Yes, please.
Okay. So if your drug is undergoing enterohepatic cycling, you will have the drug possibly being like this, the curve. It will go up because of absorption. It will go up because of absorption. Then distribution will come in. It will get distributed. It will get metabolized. But then there will be no elimination. So you end up having the drug being this way. Even if it begins to reduce, it's going to be reducing very, very, very what? Gradually. So the drug that should have been eliminated after 6 hours is now staying in your system for even up to 12 hours.
Okay.
Do you see that? So it's
Yes.
going to be reducing the rate of what?
12 hours.
Elimination. Yes. The drug will stay longer in your system and it will make the slope long. The curve will be long. Yeah.
Okay, thank you.
You're welcome. So the next question is Esther. Esther Sir. If Esther is not ready for us, then Ibrahim Sumaya.
Yes, sir. Please, sir, with the same diagram, the adverse response, if it happens, and you said we should repeat the drug again, and per the interval we give drugs, let's say the example you gave us, the woman still complaining of headache. Do you still give within the intervals you are supposed to give your medication, or you can give earlier than the next dose? Thank you.
Okay. So your question is, you have given the medication and the person has the person is experiencing adverse effects. But in addition to the adverse effect, the drug is no longer working in the person. So your question is, do you wait for it to come down here into the subtherapeutic region before you dose again, or do you still dose when it is still here? Is that your question?
Yes, sir.
Okay. You don't dose again, because if you dose again, whilst it is still within the therapeutic window, you can drive it up into the side effect region where they will experience toxic effects. So the best thing is that, so for example, if you gave paracetamol and then the person, paracetamol is supposed to work for about 6 hours, but within the third hour, the person begins to complain of headache again. Don't give para again. Search for a different drug like diclofenac.
Okay.
So that drug will now come and do its work and have its own separate slope.
Okay.
So let's not come and add to this one and drive the person to the side effect region. So choose a different drug that can still do the same work, and then it will be able to do the work for you. But if you choose the same drug, you are risking the plasma concentration going too high in the person's blood, and it can be problematic for that person.
Thank you.
You're welcome. You're welcome. Juliana Yabua.
Sir, please, my question has been answered. It was about repeating the dosage of a drug if you don't see the therapeutic effects of it.
Okay. Thank you.
Sir,
Thank you. Yes. Who is that?
please, about the plasma concentrations. Some of the drugs we give start dose and then later we do maintenance. Is it that it's going to stay between the therapeutic window, or it will start from the absorption and then it will come?
You see, sometimes if you've realized, the start dose you give sometimes is higher than the maintenance dose, right?
Yes, sir.
Why do you give the start dose? So that you can drive the concentration in plasma very, very, very high very quickly. So that within a short time, boom, you are here. Then as the concentration begins to drop, then you will now start doing the maintenance dose to ensure that it remains at this point. to ensure that it remains at this point. So the start dose you are given is usually higher, so that you can quickly drive the concentration in plasma very high. If it goes in very high, it can start working in your system very quickly. Then you give the maintenance dose to ensure that the concentration stays inside the therapeutic window. If you give low dose, it might take a longer time before the drug enters the therapeutic window. But if you give the high dose, it will enter the therapeutic window very, very, very quickly. So that's the reason why they do it that way.
Thank you, sir.
You're welcome. You're welcome. Rita.
Sir, this is Justina.
Sir, please.
What's your question?
Please, my question is about the renal exclusion. Please, you said it shouldn't be protein bound, but under the tubular, please, I stand to be corrected though. I heard plasma protein bound there. So please, I wanted to know the difference between the plasma protein and the protein bound, which shouldn't happen. Thank you.
So when it comes to the protein binding of the drug, when the drug is protein bound, it cannot undergo glomerular filtration. It cannot undergo glomerular filtration. But if it is protein bound, it can undergo tubular secretion. It can undergo tubular secretion. Sometimes during the tubular secretion, the body is able to remove it, or the transporter is able to remove the drug from the protein, so that only the drug is going to be sent into the tubules of the nephron. But if any drug is protein bound, it will not undergo glomerular filtration. It has to go through the side, which is the tubular secretion, where the drug can be cleaved from the protein and be sent alone into the tubules to get excreted. I hope this helps.
Sir, please, with the not protein bound, which shouldn't be part of the renal excretion. The glomerular and the tubular are under the renal exclusion. I heard is types. So if it shouldn't be bound, my problem is where when it gets to the tubular and there is protein, it can get bounded.
That is, look, let me come back here. Okay. If your drug is in the blood and it is bound to proteins, that drug cannot pass through the glomerular filtration to enter inside here, because the filtration will not allow for the proteins to pass through. And if your drug is bound to the proteins, they can't pass through here. If you go through tubular secretion, the transporters that are at this point are going to be selective for only the metabolites. So they might end up separating the drug from the protein and only let the drug enter inside the tubule, leaving your protein in the blood to keep on going and do its circulation. So what you end up entering inside the tubule is going to be only the drug, not the protein, so that you will not be excreting out proteins.
Okay, thank you, sir.
You're welcome.
Sir. My question is around
I am calling according to the order at which people have raised their hands, so you to get to your turn.
Sir,
Yes.
please, can you throw light on the tubular filtration for me? I think my network was jumping.
There is no filtration, it is secretion.
Secretion, sorry.
Like I said, if your drug is an organic acid or organic base, but it is water soluble, it cannot undergo glomerular filtration. There are transporters that are lining the side of the tubules that will carry these organic acids and organic bases and send them inside the tubules of the nephron to get excreted. So that is all that is done here. The organic acidic drugs and organic basic drugs are going to be sent through the side of the tubules to go inside the tubule and get excreted in the form of urine. That is all that is happening here.
Okay. Thank you.
You're welcome. Next question is Justina.
Sir, please, you made mention of something like anion and
Yes.
cations within this
Yes.
diagram. Please, I didn't get it. If
That's
you can
those
explain
are
it
the
for me.
transporters. I told you they are transporters that will carry the organic acids and organic bases into the tubules. And those transporters, we have two main types. We have the organic anion transporter and the organic cation transporter. Those are what will carry the organic acids and organic bases into the tubules to get excreted.
Sir, please, when you
I want
were
to
explaining the
find out, sir. So if it is water
Justina,
soluble, please let me answer. Yes, please. So I want to find out if it is water soluble. Does it mean that it will be the anions that will be transported through the walls of the, I don't know the name, crowd.
The tubule.
Sir, I don't. What I want to say is that the tubules. So if it is water soluble, will it be the organic, or if it is the liquid soluble, it will be the cation? That's my problem.
No. So when you have water-soluble drugs, some of them can exist as organic acids. Some can exist as organic base. They are not lipid-soluble. Organic acids and organic bases, they might not all be lipid-soluble. They might be water-soluble. If your drug is an ion, if it has an ionic property, it is most likely going to be water soluble. So if it is water soluble and an organic acid and organic base, it is going to be sent into the tubules through tubular secretion. So tubular secretion are for water soluble drugs that are organic acids or organic bases. Does that help you?
So, sir, yes, sir. Sir, so the renal and the binary exclusion side. Please, let's go to that place and answer. So that place, you mention of drug and resistance. Like circulation of drug, it can circulate several times. So that's why there's always drug resistance, right?
I didn't mention resistance.
Sir,
I
can you
said
hear me?
drug. I can hear you.
Can you hear me?
I can hear you.
Okay.
I can hear you. I didn't say drug resistance. I said drug toxicity. If the drug is staying longer in your system, the drug can be accumulated because you are still dosing. They told you to give the medication morning and evening, but you don't know the drug is undergoing enterohepatic cycling. So you're still doing your morning and evening dose. The morning dose is still there. You're adding evening dose to it. So it can lead to the drug beginning to accumulate in your system, leading to drug toxicity. Leading to drug toxicity. I didn't say resistance. Okay.
So as a nurse or a midwife, how would I know so that I will not?
That's the thing. You
as a nurse or a midwife, how?
There is no physical way of telling, but then there are certain drugs that are. There are certain drugs that are prone to